So good morning and hello everyone. Welcome to today's event, Past, Present, and Future, HCCNs and the Health Centers Using Data to Drive Clinical Care Series, Part 1, looking back at the birth of HCCNs, the Vision for Data, sponsored by the National Association of Community Health Centers. My name is Elizabeth Breidenbach. I'm a meeting and event specialist based in the Clinical Affairs Division here at NAC, and I'm pleased to bring you this event along with my division colleague, Ron Yee, the Chief Medical Officer and Senior VP of the Clinical Affairs Division. Before we get started, I would like to review a few housekeeping announcements. You have joined this online event by either physically calling in or using computer audio. All attendee lines have been muted and will be muted for the duration of this event. The duration of this live event is approximately 45 minutes, including introductions, presentations, and of course, a live Q&A. Again, the duration of this live event is approximately 45 minutes, including introductions, presentations, and a live Q&A. The Q&A box is located in the lower right-hand side of your computer screen. Feel free to type your questions into this box at any time, and we do want to thank you for all of your robust questions that you have submitted in advance. This is what we're essentially going to use to kick off today's event. But again, throughout today's event, as questions come along, feel free to use the Q&A box. Simply type your question, make sure you select to all panelists, and ensure that you hit the send button, because that's the only way we're going to get it. Again, please use the Q&A box located in the lower right-hand side of your computer screen. Friendly reminders that today's event is being recorded and will be available on the MyNAC website. Attendee lines have been muted and will be muted for the duration of this event. The Q&A box is located in the lower right-hand side of your computer screen and will be open for the duration of this event. And if we cannot answer your questions in the time allotted or we need additional resources to answer those questions, we'll post those in a live Q&A document that we'll post along with the recording of today's event. At this time, I'm going to turn things over to Ron, who's going to be introducing today's speakers and essentially setting the stage for you guys. Again, thank you so much. We look forward to having you. Ron, the floor is yours.
Good morning. Thanks, Liz, and thank you, everyone, for joining us today. I wanted to start our time together with a quote from the past, and this is where the health center controlled networks, the networks came about. And the statement, due to the rapid and fundamental changes in the healthcare environment, it is neither desirable nor acceptable for health centers to operate in isolation. And this was the Bureau of Primary Healthcare working during their Integrated Services Delivery Initiative. This was the precursor to the HCCNs and the network program. And even back then, they were thinking about this and understanding that the health centers really need to come together to work together. So I think we wanted to start with this and give you that thought as an overview. But today's webinar will be a dialogue between two visionaries of the health center movement. Many of you know Dr. Fred Rockman and Dick Bohr, who have been instrumental in moving us forward. This discussion will help us gain clarity for the future by understanding the past. And so as I mentioned, we're honored to have leaders who have shepherded this movement through the vision of data back in the 90s, and really a celebration today of what's been accomplished now in 2021. As I mentioned, we have Dr. Fred Rockman, who started as a health center pediatrician and is now the Chief Executive Officer of Alliance Chicago Health Center Control Network. He's the co-founder of that network that started back in 1997. Dick Bohr, has a 34-year history of career in the public health service, retired Rear Admiral. He was Assistant Surgeon General and the Director of the Community Health Center Program, which is the equivalent to Jim McCrae today. So we are so pleased to have these visionaries on the call with us with so much experience. I think we want to drill down, but more importantly, to identify ideas and observations that are relevant to health centers today, primary care associations, and health center controlled networks. This is critical for us to understand as we move forward. So the objective is to position the health center movement to be able to respond to current drivers in the environment in a new way. So we want to learn from each other and go from there. So I want to turn it over to Fred and Dick now, and we'll let you start your dialogue. Thank you, gentlemen.
Thank you, Ron. Good morning, everyone. Good morning, Dick. I think I get to be first up with the question here today. So to start us off, Dick, there's an old adage that necessity is the mother of invention. So if you take yourself back did that apply to networks? What was the necessity that prompted HRSA to create the early network initiative? Why was HRSA interested in them? And from your perspective, what led actually the health centers to generate that idea?
Thanks, Fred. Good morning, folks. And Ron, thank you for the opportunity to share, a little bit of history, but also, what you said with a perspective of, the future and where we're headed. So if you think back to the early 1990s, there was a lot going on, in the country, and the healthcare environment in particular. We saw, several things. One, federally qualified health centers were established in first Medicare and then Medicaid statute as a provider type. Probably the single most important thing to affect health centers now outside of the direct grant funding. Those actions, especially the establishment in Medicaid statute of federally qualified health centers, brought more revenue opportunities to health centers than any other non-grant type of thing. Secondly, you'll remember that the country was looking at healthcare reform. This was during President Clinton's first term, and there was a tremendous amount of effort, focus on the healthcare reform for this country. Even though it resulted in nothing other than a lot of work, it probably, in fairness, set the stage for the Affordable Care Act that was to come online 14 years later. And then what we saw in the mid-90s was the first attempt of state Medicaid agencies to put the Medicaid program into managed care. Again, something that was tried with differing degrees of success. Ultimately, rolled back, but now, as we know, is something that is prominent across the country with Medicaid programs. The other thing is we had gone through a period of time with health centers, where a tremendous number of health centers had been started, during the late 70s. When resources were constrained in the early 80s, there was a need to examine, that universe. And back to the quote, we saw that there were a number of small to mid-sized health centers who, were in need of support. So there are other things we could talk about in the environment, but the result, were that while health centers had tremendous opportunities, there were realistic challenges, and demands that they were having to deal with, different, than what had come before them. They were, in a situation, where what had worked in a kind of a fee-for-service, environment, it wasn't going to work, when you got into a cost, payment and or a managed care, arrangement. So what we would hear in the Bureau at that point in time were two things, relevant to what became networks. One, we can't afford the people that we need to come to the table and help us with what we're trying to create, manage, and succeed with. And secondly, we know we've got to get a handle on the data, and come up with better ways to do that. So with that in mind, to me, then that was the necessity. How do we get, skills that health centers, were requiring, but couldn't afford individually, to them, and how could we help, make some decisions, that would put them in a better position to manage data, that they collected. And so we found a sweet spot, okay, where, within the Bureau at that point in time, we said, okay, you've got a need, but we've also got a need. And that, again, I'll go back to that statement that Ron, read a couple of minutes ago. And so what we said was, if you can identify, a relevant need, and we didn't prescribe what the need was, we didn't prescribe the geography, that the need had to encompass, but we did say, once you've defined that need, you've got to show that there is commitment of a group of health centers. And remember, at this point in time, primary care associations are really just also starting, okay, to come into, to the position, okay, of influence that they now enjoy. But we said that, show us a need, show us a commitment, and we'll work with you to provide some resources, to get that started. So for me, that's not, I know, short, Ron, but it kind of hits some of the highlights. And Fred, that's some of the things I remember when I look back, golly, 26, 27, 28 years now.
Thanks, Dick.
So let me take a chance to maybe throw one at you, Fred. And maybe one of the things we probably should have done, Fred and I are going to use the term networks, okay, for the next, 30 minutes, 32 minutes. That'll encompass a lot of different things. I mean, I can't even remember the number of titles for funding opportunities. But, as Fred and Ron both said when they started, today they're called health center controlled networks. Except if you're in California, then they're called consortia. Okay, but the consortia of California are also health center controlled networks. And I know I'm going to ask you a question, Fred, but I want people to make sure they understand health center controlled networks is actually a term defined in Section 330 legislation. So remember, okay, there is a legislative base, and we could go through that story, okay, if we wanted to. But with the networks, Fred, we had this idea, of operational networks. We had the idea of health center control, and we also knew that, that if you were to look at a timeline, okay, stuff didn't happen overnight. So what do you see, okay, from, because you were there, you were in the real world, I was in the Bureau. What do you see, okay, as kind of that evolution from operational to ensure control health centers and kind of the stages that things went and evolved through?
Well, Dick, you're taking me back, but really I think that originally when networks were laid out, the gold standard that was promulgated were these two pieces that you talked about. One was the health center controlled feature. And I suspect that had to do with sort of similar to the way health center boards need to be comprised of users of those services as a majority. I think the same thing pertained here. The idea was that in order to assure that these entities wouldn't go rogue and they remained true to the needs of the health centers, that they were actually controlled by the health centers themselves. And I think that was important to get buy-in from the health centers. I also suspect, you would know better than I, it might have been important also to justify funding them under the 330 funding pool. But the health center controlled nature was certainly important, but the other was the idea of the operational network as being the ultimate. And the way we understood operational was that health centers were actually now performing some key core operational function together through a network infrastructure rather than individually. And the test would be that if you remove the network now, these health centers would literally hemorrhage because they were performing some key function together as a group. That was kind of the gold standard. And I think there was a vision you couldn't get there overnight. You couldn't just get there overnight. So there were these stages of evolution that were laid out, and there was funding attached to each of those stages. It began with planning for health centers to spend some time, take their time identifying where was that common function. And then the next stage up was sharing, where they actually began to share things, resources, ideas, whatever, but they were still operating pretty independently. And then the next stage up was collaboration, where now the health centers were doing things collaboratively, but still independent, in finally getting to this final stage where hopefully through all of that had identified these opportunities where they actually could perform together at scale, at economy of scale and efficiency of pooled resources, some function that they had identified. So those were the stages that the early networks worked their way through.
Hey, Fred. I've got my perspective on this question. I'd be curious to let you start. We talk a lot about leadership, okay, in any kind of movement. Where did leadership, okay, come into this equation at the health center level, at the network level, at the federal regional office level, okay, as well as the Bureau of Primary Health Care?
Yeah, what a great question, Dick. So first of all, a mentor to me was we couldn't have this conversation without mentioning Betsy Cook, who I know you'll acknowledge as being one of the originators of the concept. And I think Betsy really capitalized on leadership at the health center level. What it took to create this concept and to champion this concept was a group of health center leaders who recognized that giving up a little bit of independence for the sake of working together as a strong group was a very, very worthwhile thing to do. It cuts across the grain, right? It's not kind of the United States way where we want to be strong, independent, we want to dominate. But those leaders really got it, that there was a secret sauce that mission-driven organizations like health centers could capitalize on. And so that vision of giving up a little bit of independence, a little bit of ego in favor of doing things as a group of health centers was key. I'd also say at the network level, it took an individual who could put ego on the shelf. Like, so all of that said, if health center CEOs were going to give over some of the control or the power to the network, it had to be to a leader there that they were not afraid was going to go on a power trip. It had to be a servant leadership model, so that leader at the network level was not now creating something over the health centers, but something that served the health centers. So I think that was key. And then that was an unusual constellation of leadership that occurred to birth the concept. And then what it took was leadership at your level, Dick, at HRSA level, to say to other health centers, look at what's happening over here. This is really a very strategic way for us to be thinking, and therefore we're going to incentivize you. We're going to resource you if you will step up and emulate that model. We are going to champion it for you. And so I think those are the forms of leadership that were important early on in getting this thing started.
Fred, I don't know if you remember, okay, a term. I doubt if it even exists in any dictionary. But there was this young attorney named Jackie Leifer, who was, again, one of the, quote, leaders, end quote, in this. And I remember Jackie, coming up with the term Subbrella, what, the vision of networks back in the 90s was that it could not be an umbrella. Okay, back to your point about, trust, and, leadership. So, Jack, as I say, I doubt if Subbrella is a word, okay, but, for people who worked with networks back in kind of in that beginning stage, it captured, the idea that, you had X number of health centers, okay, who had their autonomy, okay, but, okay, they were undergirding for certain essential functions, okay, the role of an entity called a network. And, a very important part, and, again, a term that for some reason I still remember. So, okay, we've talked, we got 25-year, give or take, history, Fred. Let's share with some folks, okay, who are with us, today, kind of some of those lessons learned, okay, about, what enabled them to succeed, and what are the implications of those lessons learned now moving into, 2021 and a new year, let's hope, okay? Now, what do you think? Some of the things we learned.
Just you're throwing these easy questions at me, Dick. I think the first was the leadership we just talked about. I think that was key, and that leadership had to exist at the health center level. Health centers had to buy into the idea that they were going to invest outside of their own independent interests, but we're going to invest together. And then the leadership at the network, the right leadership at the network to, have that Subbrella, I love that term, approach, not the umbrella approach. I think the next thing was it had to be resourced appropriately, and that still exists. Like, in order for there to be a value that gets delivered, there has to be an investment in it. That means the health centers have to invest in it, that the resources for health centers to invest in it needs to be recognized. And the network itself has to be invested with enough infrastructure that it could return some actual tangible value to the health centers. I think the other thing is finding that those key areas where the value is going to be apparent to people. It has to be clear why this would be a valuable thing to do. And then I'd also say there's like this equation of like a large health center versus a small health center. We have to figure out a way that there would be a return at all levels. So it might be less apparent at first blush why a large health center should be investing with other health centers, because the gain in terms of scale and size of resources might be less apparent than it is for a small health center. So somehow the sum of the parts still needs to be greater, even when you're looking at it from a large health center point of view. You can trade on altruism, you can trade on the view of the larger good to a certain extent, but it also needs to be apparent how at the end of this investment the value is going to be there across the board. So those are just some thoughts, Dick. You may have others.
Well, I think the let me just elaborate a little bit more on kind of that last point you were trying, I think, to make, Fred. I think if I were still in the federal government in a role with HRSA or the Bureau, I think I would be in a similar position. I know that Jim McCrae and people like Sue Manair and I know they are, and that is any appropriated dollar that is not associated with a direct service, can be challenged by a bean counter. Somebody in the budget and management part of either the Department of Health and Human Services or within the Office of Management and Budget. So it was, terribly, terribly important early on to be able to convince the bean counters. It's still going to, important, and it's going to be important in the future to convince the bean counters, okay, that these, resources, while they may not be to start a critically needed service, while they may not be, to open, a site in an underserved area, okay, they are equally important, okay, to the overall health center program and the support of it. I will throw another phrase at you, Fred, okay, since it was directed at you in a meeting years ago. And, the Fed said to you, okay, he picked up on a commercial from a fast food restaurant that was popular at the time. Show me the beef. Show me the beef, okay, and that became a rallying cry, okay, as I remember, Fred, for networks to say, wait a minute, okay, they're trusting us, okay, we got to show results. If Jason Greer, okay, or Diana Irani, okay, or Fayez are on, okay, with this chat today, they, as the leadership, okay, of the HCCN, task force within that, know, okay, the standing item that they focus on is return on investment, okay, showing what difference, okay, it's a relatively small investment, but what difference that investment's making. And that's going to be with us, folks, okay, going forward.
So Dick, what I think is that return on investment, again, it gets back to what is the right thing, what's the right reason, or what's the right area for a network to focus on. And, I think the return is different at each level that we talked about, planning, having health centers work together, plan together. Certainly, I think you could come up with some return on that investment so that if health centers are looking at needs in an area, and rather than coming at it independently, they're at least taking the time to plan together, that they're liable to come up with then a path forward that's going to make better use of resources than if they just go about it independently. Collaboration, certainly sharing ideas, you can come up with some return on that. Collaboration, you could definitely come up on a return. I think at each stage along the ladder, the return on investment is greater. And when you get then to this integration, I think you have an even greater return on investment because now you're making investments once in sort of expensive areas if you choose them right, rather than several fold. And you have economy of scale. You have the ability to afford much greater levels of resources, et cetera. So it's a better kind of investment than if you invested health center by health center. It's why a Kaiser can do things at that scale that even the largest health center that we see could not do. So that's what I'd say is intuitively that's there. The problem is it's kind of a chicken and an egg. You have to have the right area where it's going to be clear if you're sitting at HRSA, I would imagine, that you should do it that way. Now, we were fortunate at our founding. We came on the scene just at the advent of electronic health records. And HRSA had invested in individual health centers to do them. And as you'll recall, there were these horrible failures, like multi-million-dollar investments that, that failed. And so this idea of, well, gee, could we fund this at some kind of scale, and would that make a difference? And of course it did. And so HRSA then decided, well, instead of taking a risk by giving health centers money individually to do this, we will invest in electronic health records as an integration. And that was the fuel for the growth of, you know, some of our surviving operational networks today. So I think, to me, if we choose the right area to invest in this way, then you can demonstrate how a dollar spent in a network is actually like investing $3 in a health center. And it should not be a trade-off. It should not be money that is taken away from a health center. Rather, it should be even deeper resources that are given to them. But it is tricky. It has to be for the right, in the right area.
Fred and Dick, thank you for this dialogue. I'm going to give you a couple more minutes. We wanted to spend a little time for Q&A if people had any questions. So you all have a couple more minutes. So please go ahead and continue your dialogue. Just wanted to give you a heads up.
Thanks, Ron. Yeah, so maybe we should, Fred, kind of share our thoughts a little bit about so what, okay? And I think you started that, okay, with the comment that you were making. Many of you, okay, know, okay, I believe, okay, we have more data, okay, than probably any other organized provider of care in this country, even some of the biggest hospital systems. Okay, unlike some of the hospital systems, we've been unable, okay, to put our arms around that consistently. So I look to the future, okay, and the need to get what I call data into actionable information. The networks are perfectly positioned. That's what some are doing, okay, right now. I think one of the challenges that we're going to have to sort out with networks, okay, is, again, how best, okay, do you accomplish that? Okay, do you need, a chicken in every pot, okay, or are there opportunities for networks, okay, to network, to make sure, okay, that we're getting information to people state and locally to do what they need to do and do it well. And I think that, that's something we should, kind of close the door and, leave the hat outside the door and think that one through. So that's my thought. Okay, Fred, I toss it back to you before we see if we've got any cues from the field.
Yeah, I mean, if I take your point, Dick, I mean, I think data analytics is certainly an area that networks might have a role for. I guess I'm also thinking about the fact that we are on the dawn of incredible disruption in healthcare delivery. If people, look at our experience over COVID, we're not going to go back to the way the things were before. I love that phrase from the head of CMS, the genie's been let out of the bottle. I mean, I think that is even broader than just referring to telemedicine. I think it's caused consumers to think in a whole different way and change their expectations of how they interact with the health system. That was born first of necessity, but then, now they've had a different experience. And it's also caused the retail industry to begin to respond and see opportunity. And then finally, it's really alerted us to the fact that the separation between what we've thought about historically as public health and primary care is not serving us. And that in a modern information age and in an age of interoperability, that separation is very artificial and needs to go away. So what that means is health centers need to think about it at a system level in a whole new way, and I think the network model is an opportunity for health centers to think about how to reconfigure the way we present ourselves in terms of the way we deliver services.
Great concluding part there, Fred and Dick. I think looking forward and the value of really having actionable data and having population health aspects as well as individual health centers. So I wanted to give a few minutes. I'm going to turn over to Ellen if she had any questions that came in for a couple of minutes if we have some time here. So Ellen?
Yes, and please continue to add in your Q&A, and if we don't get to them, we will get to them another week. First of all, I just wanted to thank our speakers for presenting what was really interesting and great detail of a lot of the history. One question was whether or not you could review the statutory language regarding HCCN grant eligibility and eligibility as identified by HRSA.
Dick, I'm hoping you take that one.
Ellen, my suggestion will be to post that section of the law. Okay, my paraphrase of it, okay, is that they, are entities, a majority of the members of whom, okay, are funded health centers. And what I can't remember, and that's why I think it should be just shared with people, cannot remember if it's funded health centers, okay, or an FQHC. I don't remember whether lookalikes, okay, are in the legislation. I'm sorry.
No problem. We will look it up and post that information. Another comment, if you can address any other examples in other industries and even in other parts of healthcare that help demonstrate the value of the work that networks do. Can you guys think of any other examples?
So, I'm going to give a strange response to that. And I'm going back to this idea of umbrella versus subbrella. What I point to is the umbrella concept, like the merger and consolidation of smaller practices or smaller entities into larger and larger health systems is the example I'd cite of why it makes sense to do these kinds of things at scale and to have like a broader a strategy that's implemented by a much larger group of health delivery points. And on the flip side, what I'd say, the subbrella is very unique. What it's counting on is this ability that health centers have because we share this mission. And by and large, I'm hoping we have a lot of servant leaders out there and a lot of altruism out there. We could choose, rather than needing to merge like that or become very large and impersonal, we could choose to exercise this voluntary giving up of control rather than being ordered to do it. And what we have to gain by that is, I am still so dedicated to the original vision of health centers, which was actually somewhere in the legislation, that they remain relatively small and responsive to the needs of specific communities. I think as health centers get larger and larger, we start to lose that. We start to look like any other part of the health system. So what I'd say is the model, the demonstration that a large network of merged infrastructure works is out there at large in healthcare. What's not out there is what we do if we preserve that unique, precious part of what we have as health centers and remain small and dependent at the community level.
Right, that is important, the community level. Getting a couple of more questions in, so want to try to answer them in our limited time. Can you expand on your closing thought on the shift in delivery model in primary care and the ability of HCCNs and data analytics to support that change?
I was hoping I could shunt that to Dick, but it seems like it might have been aimed at me, but I'm curious about Dick's thought too. Yeah, I think so. First of all, digital health. We're in the era of digital health, you know, analytics is now actually going to be a service. When you look at precision medicine, at the heart of it, it is taking data at scale and turning it back into more and more precise recommendations that are more individualized. And in order to get to that scale, you need large volumes, large populations and volumes of data. And then the other thing is that care is uncoupled from a particular delivery site. So there's opportunity then to think, if we're not limited by a geography or not limited by an office visit, what is it that we could do as a healthcare delivery network? I think, you know, those are some immediate examples of what you do at scale and what we begin to see happening at larger healthcare systems.
My comment would be, you know, pretty straightforward in the sense of when you look at the role networks have played across the country over these last 10, 11 months, you know, what you see, okay, you know, is their ability, okay, to help, okay, their members and discern what the member can do with its own capacity and what, okay, it can better do, okay, by relying on its Subbrella network, and that, you know, that balance, okay, and you know, we've said it before, but you know, that, you know, striking the balance between efficiency and autonomy, okay. Yeah.
Well, thank you, gentlemen. We appreciate that. You know, I see, and I've seen it on the clinical side, but also population health, the value of the networks, and I think especially as you mentioned these last months of COVID. The networks really have information that even the CDC doesn't have, down to the level of social determinants of health, you know, where the positive tests are coming out, tracing, all that. And now with the vaccines, I think the health centers are going to play a key role. But we've got to be given the right resources, and there's certain things that need to be fixed before we can really help our patient population. So it just shows me how important our networks are. And I want to thank all our network folks that are on the call and people that have invested in this. Thank you, Fred and Dick, decades of your time and effort and visioning. So I want to thank you for sharing with us today. And you know, it's amazing to be able to be spectators of visionaries, a conversation between you two, to be able to get in on that and to get to hear your thoughts. So we want to thank you for that and for all you guys have done and others through the years to build up where we are. So thank you so much again. And thank you to the NACHC staff for setting this all up. Just a couple of reminders to finish off. This is the first of the three-part series, as Liz mentioned at the beginning. So our next one will be next week on Tuesday, January 26th, a week from today at 11 a.m. Eastern Time. At that time, we're going to have Suma Nair from the Bureau of Primary Healthcare talking about the current role of networks. So I think that's going to be a really good one. And then we'll follow with the last one. It'll be through the lens of the future with two models using data and the FHIR apps. So the fast healthcare interoperability resources, using those apps are really going to be key going forward. So that's going to be the third one. Also wanted to remind you about this Friday. We have our Ask Me Anything session, Q&A at 12 noon Eastern Time with Claire Hannon, the director of the Association of Immunization Directors. And there's other things going on like office hours, FTCA Office Hours, and other things related to vaccines. So just go to the NACHC website to get those. So again, thank you so much, everyone, for joining us. Thank you again, Dick and Fred. We are here to support the work of the networks, and I think we're trying to figure out that right combination of that Subbrella, of the independence but sharing together to have impact on our patients, and that's what it's about, is impacting and having that actionable data that Dick mentioned to really give our patients and populations the very best health care we can do, and to collaborate with others using data to inform us in our decisions and to really have an impact. So thank you all for all you've done and you are doing, and everyone involved with this call for the setup. So we'll see you back next week. Thank you, everybody.